This lecture is about the evaluation of a knee pain. So, when evaluating a knee pain, you have to check the many aspects of a knee. This may include your history, including the age, location, onset, duration, and the quality of knee pain. Like if there is any history of a swelling present, any trauma, any previous medical or the surgical procedure that can lead to your present knee pain. So, first one is a site of pain. So knee joint receives innervation from L3 through S2. So most of a knee problem affect the interior medial or the medial aspect of a knee, which is innervated by the L3. Because the L3 segment usually does not extend much below the knee joint, it is rare for the patient with the knee disorder to experience pain radiating further down the mid leg. So, most of the knee pain can be referred proximally into the interior or the interior medial thigh. So, the interior aspect of the hip joint is also innervated by the L3. So, referred pain of a hip joint may be similar inside that arising from the knee. In most of the patients with a non-traumatic onset of a knee pain about the knee, lesions can be situated in anywhere between the L3 to the S2. So there are two most common sources of a rapid pain to the knee. One is the lumbosacral region and the other is the hip region. So if the pain is felt over the posterior aspect of the knee joint, so it can be related to the distension of a posterior capsule because the S1 and the S2 segment, which innervates the posterior knee region and they extend to the foot. So posterior knee pain can be referred some distally. If the pain is of non-traumatic origin and it is generalized in nature at the interior medial aspect of a knee, it is most commonly felt from the patellofemoral joint dysfunction and it is aggravated by descending stairs and prolonged sitting. If the pain is in the interior medial side and the pain it is localized in nature and is sudden onset, it is often related to the meniscus injury. The pain arises from the medial coronary ligament. But if there is a medial knee pain of traumatic onset after a valgus or a rotatory strain, it is usually of a capsuloligamentous origin. A tear of a meniscus must also be ruled out. Next is the onset of pain, whether a pain is of sudden, gradual, traumatic, or the non traumatic onset. First one is the sudden traumatic onset. So, in sudden injuries caused by the trauma are common, especially from the sport activities, contact, or sudden changes in our direction. So, if there is a sudden twisting injury in which the tibia is rotated externally on the femur without an external source of force, this tear this may be present a tear or the capsular fibers of the MCL. There may be a coronary ligament injury or there may be injury of the body of a medial meniscus. But when some external force is involved, such as in the contact sports, and the knee is also forced into a valgus position, the posterior medial capsule or the MCL or the ICL may be damaged. But if the onset of pain is a gradual and it is non-traumatic in origin, it can be related to the degenerative joint diseases. So it must be ruled out. If pain from a degenerative joint disease is typically noticed first near the end of the day or after a long period of walking, and then later pain and stiffness are felt on rising in the morning, and it is and after getting up and about. So, possible precipitating factors such as recent immobilization, or if there is alterations in activities, or if there is present any past injuries and a previous surgeries should be considered. But if there is a patellofemoral joint dysfunction, a common knee problem is frequently related to your quadriceps insufficiency. There may be a quadricep weakness from a disuse or from an excessive knee extension activities. Pain of traumatic origin, a pain secondary to a traumatic typically felt immediately at the time of injury. A minor or moderate pain of a medial capsule or a ligament is painful at the time of injury than a complete MCL injury. Next is the effusion. So, what is joint effusion is that when too much fluid accumulates around a knee joint, this is commonly referred to as a swollen knee. So, it most commonly follows a traumatic injury to the knee joint. This may also result from the blood filling around the joint or if there is overproduction of a synovial fluid. So, the time frame of the onset of the effusion often provides important insight to its nature. Like if there is hemarthrosis, it means when there is a blood in a joint, it tends to develop in a short period after the injury, like from minutes to a few hours. But if there is a synovial fluid present, if there is a synovial effusion, it may occur during a long period. It may occur from 6 to 12 hours before it is noticed. So, synovial effusion causes a dull, itching pain from a distension of a joint capsule, but whereas hemarthrosis may be associated with more severe discomfort, which is caused by the chemical stimulation of a capsular nociceptors. Next is a patellofemoral joint pain. So, when a pain is felt when sitting for a long periods with the knee bent or when descending stairs, so both these functions involve high and a prolonged patellofemoral compressive loading. So, pain is felt mostly on descending than on the ascending stairs because there's a greater passive tendon tension is developed in a quadricep mechanism during the eccentric contraction than during a concentric contraction. So sitting is basically a problem with a patellofemoral joint pain. Next is a morning pain. So pain is present on wakening and it subsides with the initial use of a joint and then increases again after some period of use, which can suggest a degenerative joint diseases. Next is a buckling or a giving way. So it is related to a functional or the structure instability. Most common cause is a ligamentous integrity and patient may cite a particular activity that is a problem. So functional buckling occur as a result of a reflex muscle inhibition because it results from an abnormal joint receptor activity. So, a common cause is the internal dearrangement from a meniscus tear or if there is any loose body present. So, in such cases, an abnormality in the orthokinematics resulting from a mechanical dearrangement may reflexively indicate a sudden inhibition of a quadricep muscle, which may result in a giveaway. So the patient usually cannot attribute the incidence of buckling to any consistent situation or activity, but claims that the joint gives way for no apparent reason.